All right, so welcome to session 3 of our training webinar. I am going to turn the program over to Melinda.
Hi, everybody. It's Melinda.
I'm going to
Uh,
stop the music too. Hold on.
can you see my screen, Nancy?
I can.
Okay, so welcome, everybody. This is our third session, and today we're going to be talking about case inclusion, selection of the index procedure, and the PROC ID chart. Um, I want to welcome all of you, and I also want to welcome my colleagues, Leanne, Nancy, Carol, Manu, Emily, and Paul. So thank you all for attending the call. Okay, so what are we gonna do today? First, the learning objectives, we're going to try to identify if the case is even included in the adult cardiac surgery database. I get a ton of questions about that in the mailbox. And then we're going to look at the required entry cases versus those optional entry cases. And then we're going to understand how to determine the index procedure for the episode of care. And then we're going to go into the PROC ID chart and hopefully better understand how to read that complex chart at the end of this session. Okay, so we're going to, again, start with case inclusion. And a lot of times I get questions, and, when I read the question, I'm not even sure there's a cardiac surgeon involved in the procedure. So when you're looking at a case, that's probably the first thing to ask yourself. Is there a cardiothoracic surgeon on your participation agreement that either performed the case or participated in the case? Okay, because if there's not one, then we can't put that case in. Okay. Now, if a participating cardiothoracic surgeon performs a surgery with a non-participating surgeon, then you have to put the participating cardiac surgeon's name in the database field for the surgeon, okay? Because that's the surgeon that's on the participant agreement. A common example of this is a T-bar. You have a participating thoracic surgeon, and then you have a non-participating vascular surgeon. They're both performing the procedure. The surgeon that gets entered into the database is the participating surgeon, so the cardiothoracic surgeon. Now, surgeons who are not on your participant agreement, who perform cases, they really can't be entered unless you add them to the participant agreement. And this question comes up a lot with locums. So we have locums coming in, they're performing cases. Do we enter their cases? Well, you need their permission to enter their cases. So they have to be on the participant agreement. So that's kind of step one, figuring out who's doing the case and are they on your participant agreement. Okay, step two of case inclusion, really you need to review the case inclusion document, which we're going to go through and talk about the required versus the optional entry cases. So this document, I recently updated this. I think it was in November. It's on the STS website, just under the training manual. If you scroll down a little bit under additional resources, and I've got the link here for you, you can find this document. Okay. So let's start with the required entry cases. So these are cases that are done in conjunction with other CV surgeries or their standalone procedures. So cabbages, okay? Any kind of cabbage is included, right? And then your valves. So if you're doing any kind of aortic, tricuspid, mitral, pulmonic valve, either replacement or repair, or even a valvectomy, those procedures automatically go into the database. if you have a participating CT surgeon doing it, okay? So, because that's step number one. And we've already got past that. So we're past step one. We know we got a participating surgeon. So now we're going to look at the case, just the case level. And then number three are aorta procedures starting above the diaphragm. And it includes dissections. So we're talking aneurysms, dissections, any type of aorta procedure that starts above the diaphragm. So those are arch procedures, ascending aortas, descending aortas, root procedures, even your thoraabdominal ones, because they start above the diaphragm. And T-bars. So we'll talk a little bit about T-bars. So T-bars with any portion that starts above the level of the diaphragm are included if a CT surgeon on the participant agreement participated in the T-bar. Now, occasionally, I will see a T-bar done, and it's completely done by a vascular surgeon. It started above the level of the diaphragm, but it was done completely by the vascular surgeon. And again, we cannot put that case in because there's no participating CT surgeon that worked with that vascular surgeon. E-bars are not included. So just standalone E-bars, that's way below the diaphragm. We don't put those in our database. Okay, moving on, required cases. Procedures performed on the heart, the aorta, the pulmonary arteries or veins, and or the inner thoracic inferior superior vena cava. So we're talking about great vessel procedures here, okay? So this would be any kind of left atrium or right atrium or left ventricle or right ventricle procedure. Get a lot of LV perforations that need to go in the database. Cardiac trauma that includes these types of structures, LV aneurysm repairs, cardiac tumors, atrial septal defects, ventral septal defects, myectomies, pulmonary thromboectomies. At times you will see a standalone procedure for a massive pulmonary emboli, saddle embolus. Those do go in our database. Standalone pericardectomy. So we have a little qualifier for that. They can go in the database if the pericardectomy is performed from the left phrenic to the right phrenic. So that would be a complete pericardectomy. Those can go in the database. If it's just a partial and it's a standalone procedure, those are not required to go into the database. Continuing on with our required cases, atrial fibrillation cases done by the cardiothoracic surgeon. Okay, so that's key. Sometimes I get questions about AFib cases done by cardiologists. Well, if the cardiologist is not on our participation agreement, of course, that case doesn't go in. But if you've got a cardiothoracic surgeon on the participation agreement and he's performing standalone mazes, LAA clips, convergent procedures, those kinds of procedures are required to go into the database. Continuing on, required cases, ICD and pacemaker lead extractions done by the cardiothoracic surgeon. Okay. And for these standalone lead extractions, these are standalone lead extractions. Enter all lead extractions, regardless of the approach, when a participating cardiothoracic surgeon performs or actively participates in the procedure. That would include even a standalone explant of the microleadless ventricular pacemaker, because even though they don't have traditional leads, they're still attached to the myocardium. So the risk of taking out leads that are attached to the myocardium and have been in for a significant amount of time is a fairly risky procedure. I know it's done a lot, but it's not without risk. Standalone extraction of leads for a subcutaneous ICD, different, not required. These are sub-Q leads. They're not attached to the myocardium. We don't require those to be entered into the database if a CT surgeon performs them. Okay, number 7, VAD explants and implants done in conjunction with CV surgery. Okay, so I'm not talking about a standalone VAD explant or a standalone VAD implant. I'm talking about VADs that are done in conjunction with some other type of CV surgery that you're entering. So a lot of times you might see a VAD implant and you might see an AV repair or a VSD repair or something like that. So those cases you would put in. But if it's just a standalone VAD, those are optional, and we're going to get to the optional cases before long. Okay, and here's the before long. We're already to the optional cases. So those are all of the required cases. So when you're looking at a case, think about the things that we just talked about. First of all, who did it? Is it a participating surgeon? And is it required? Now, we're going to talk about the optional cases. And when I'm going to preface it by saying, if there is no required entry case performed during the episode of care, okay? So these are, generally speaking, standalone type procedures. You don't have another index procedure that's required to go in, and you're just trying to decide whether you should put this case in or not. So step number 1, optional cases should be entered at the discretion of your CV surgeon or surgeons who are on your agreement. So if you're trying to decide whether you want to enter a standalone pericardial window, you probably need to talk to your surgeons and say, is this a case you want us to enter into the database? So we're going to go through this list. Here's our optional cases. And this is if there's no required entry case performed. So if you are doing a standalone ECMO, Impella, any kind of temporary assist device, or a balloon pump insertions, those standalone procedures, the only thing you did during the episode of care, those are optional to enter. Standalone VADs or implants or explants, there's a whole registry for those. Standalone hearts, total artificial hearts. Standalone TAVRs, TAVRs, transcatheter mitral valve replacements, mitral clips, transcatheter tricuspid valve replacement, tricuspid clips. So all of these TAVR or transcatheter valve replacements or repairs are not required to be entered into our database. They are entered into the NCDR database that in conjunction with the STS database. So, but you don't have to put them in both. It's optional. Talk to your surgeon about that. Standalone pericardial windows, pacemaker, ICD insertions, and lead insertions. Now, when we're talking about this, remember, we're talking about your cardiac surgeon on your agreement doing these procedures. Standalone lung transplants, they don't have to go in. They're optional. Standalone heart transplants. They really should all be going in the UNOS registry. They're not required to be entered into our registry unless your surgeon wants them entered. Standalone angiovac. Whether you're removing them material from a valve or you're doing a pulmonary thrombolectomy, you know, these procedures are optional to go in. I'll mention a few things. If you decide to put a standalone angiovac case in where you have removed matter from the valve, then we don't want these coded as valve procedures. We would like those coded as other cardiac procedures. The same thing for a standalone percutaneous pulmonary thrombolectomy with a flow retriever or angiovac device. We don't, those are optional to go in. If you decide to put them in, enter them as another non-cardiac vascular procedure. We don't want them entered as a surgical pulmonary thrombolectomy. Okay. The next optional case are standalone endovascular aortic valve repairs. Okay. They don't have to be put in. They're optional. If you put them in, we want to put it as other cardiac other. Repair of an LV aneurysm using a transcatheter approach. If you put that in, other cardiac other. Variosteum placement procedures. These are optional, other cardiac other. Okay, so we've went through the list of all the procedures that are required and the optional procedures. Now I want to talk a little bit about determining the index procedure for your episode of care. So the first and very most important thing I want to say is there's only one data collection form and one index procedure for your site per episode of care in adult. This is different from congenital. And I know I get a lot of questions about, well, he had this procedure and then he had that procedure. Do I start two forms? We never start two forms in the same episode of care. There's only one index procedure for adult. The other important thing to know before we get started is canceled or aborted cases without any procedure performed. They're not entered into the version 4.2. We used to capture those in prior versions, but we don't do that anymore. And a perfect example of this is a dissection. They open the chest and the patient codes and dies. There was nothing done except opening the chest and then, of course, trying to resuscitate the patient. There was no procedure performed. We would not put that case in the database for version 4.2. Okay, so how do we choose the index procedure? We've got some principles here to follow. And then once we get through these principles, we're going to go into some scenarios to further solidify case inclusion and choosing the index procedure. So the number one principle in choosing your index procedure is required entry. Analyzed cases are your top priority. So if you have one of them, then that's your index procedure. For example, if you have a cabbage and you have an LV repair, well, the cabbage is analyzed. The LV repair is not analyzed. So your cabbage is your index procedure. Number two principle. Always enter required entry cases over optional cases. So if you have a TAVR and then a SAVR, the SAVR is your index procedure because TAVR is optional, SAVR is required. The third principle, if you have two required entry cases, neither of them are analyzed, then choose the first required entry case where a procedure is performed on the heart, the aorta, pulmonary arteries, veins, and or your superior vena, inferior vena caves. An example of this, you have an aortic dissection repair followed by an RV perforation repair. Neither one of these cases are analyzed. They're both required entry. So we're going to choose the first one that occurred, which would be the dissection repair in this situation. There is one little caveat to this. And I think I've pretty much identified the only example currently for this. If one of the two non-analyzed cases has a risk calculator and the other does not, then enter the case with the risk calculator. For example, you have an ICD lead extraction followed by a TV repair. Enter the TV repair because we have a risk calculator for the TV repair. Neither one of these are analyzed currently, but we do have a calculator for the TV repair. So we would want that TV repair to get entered over the ICD lead extraction. The last principle before we get to our scenarios. If you have two optional entry cases, such as a standalone VAD and then a heart transplant, and your surgeon wants you to enter these optional cases, then the transplant's going to be the index procedure. Okay. So now that we've gone through all our principles, how to choose if the case goes in, and then how to choose the index procedure, we're going to go through some scenarios now. And we're not going to do polling, but I'm going to have little fly-in answers, so I'll give you some time to think about your answer. Okay. So the first scenario is on case inclusion. Your pre-op diagnosis is a massive saddle pulmonary emboli, cardiopulmonary collapse, morbid obesity. Your post-op diagnosis, massive saddle emboli, cardiopulmonary collapse. Procedure performed, mediastinal sternotomy for a surgical thrombectomy of the saddle pulmonary embolus and bilateral pulmonary emboli. Institution of VV ECMO. Is this case included in the registry? Okay. So it is required entry because we performed a procedure on the pulmonary artery or pulmonary veins here. We were removing a saddle pulmonary embolus. It was a sternotomy. It was a surgical, open surgical thrombectomy. It is included. Scenario number 2 for case inclusion. Left atrial laceration, cardiac tamponade, cardiac arrest, hemorrhagic shock, secondary to attempted Watchman procedure. The name of the procedure. They did a sternotomy. They went in and explored and evacuated a pericardial hematoma, and they repaired a complex left atrial laceration. Is this case included in the registry? Required entry. Okay, so it's required entry because they went in and they repaired that left atrial laceration. The Watchman in this particular situation Watchman that's being done by the cardiologist is coded as a prior CV intervention. Next scenario. This is a robotic left atrial clip with the Da Vinci system 3-port approach performed by the cardiac surgeon. Do you include this procedure in the registry? Yes, it's required entry. It's an AFib case done by the cardiothoracic surgeon. It would go into the registry, required entry. Okay, next scenario. Pre-op diagnosis: chest pain, retained foreign body, and pericardial effusion. Procedures: subxiphoid pericardial window, open removal of a foreign body under cardiopulmonary bypass, tricuspid valve repair with patching of the anterior leaflet and a 32 millimeter tricuspid ring. So do you include this case in the registry? It is required entry, and the reason is because they did the tricuspid valve repair. So if they had not done the tricuspid valve repair, they just did the window, you wouldn't have to put that in. But they did the tricuspid valve repair, so it goes in. Okay. Next case scenario inclusion. Subxiphoid minimally invasive epicardial ablation convergent procedure done by CT surgeon. So this is your CT surgeon. He's doing a standalone convergent procedure. Are we going to put this in the registry? Yeah, it's required. It's an atrial fib case done by a cardiothoracic surgeon. The surgical component of this convergent maze completed by the cardiothoracic surgeon is captured in the AFib section. We have a choice for that, primarily epicardial and epicardial posterior wall other. And we're only capturing the surgical component of the convergent procedure, which is completed by the cardiothoracic surgeon. We're not coding the cardiologist portions. Okay. Case inclusion. Okay. Reduced sternotomy, right axillary arterial cannulation, aortic arch debranching, ascending to a nominate artery bypass, ascending to left common carotid artery bypass with a trifurcated graft using bypass. Do we include this case? This is the only procedure that's being performed in the episode of care. Okay. So if this was a standalone procedure, it's the only procedure that you're doing in your episode of care, then this isolated head vessel case does not have to be entered into adult cardiac surgery. I mean, they're basically doing vascular bypasses here on the innominate and the carotid. They're not really doing an aortic procedure. They're not really doing a heart procedure. It's more of a vascular procedure. So if this is a standalone procedure, the only one you have, it's optional. Talk to your surgeon about it. If he wants it entered, and then you would choose to enter it as other vascular. Okay, so now we're going to move on to index procedure scenarios. Okay, so patient arrested during the cath lab procedure. The CT surgery was called emergently for ECMO placement, and in the same admission 3 days later had a redo AVR. So what's your index procedure here? So standalone ECMO is optional to enter, okay? Some sites enter it, some don't. The AVR is required entry, and it's also analyzed. So always enter the required entry cases over the optional. So your AVR is your index procedure in this particular scenario. Next scenario. Patient had a correction of anomalous origin of a right coronary artery with reimplantation. Patient had signs of myocardial ischemia post-op and was taken back to the OR for emergency CAB ×1. So what's your index procedure? Let y'all think about that one for a minute. Okay. So correction of the anomalous RCA is required entry, but it's not analyzed because when we're just correcting an anomalous RCA by doing a reimplantation or an unroofing, that's a congenital procedure. We don't analyze them, but they're required to be entered. The cabbage is required entry and it's also analyzed. So again, the required entry analyzed cases are your top priority. So if you got one of them, that's your index procedure. And we do have one. We have the cabbage. So the cabbage in this situation is the index procedure. It would be an emergency cabbage. That would be your index procedure. Okay. Next scenario. Patient presented with a multi-vehicle accident and he had cardiac trauma. He was taken to the OR for an LV perforation repair. 4 days later, the patient complained of severe back pain and was found to have an acute type aortic dissection and was taken back to the OR for that aortic dissection repair. So what is the index procedure here? We've got a few choices. We'll go through this. So your LV repairs require an entry, but it's not analyzed. Your aortic dissection is required entry, but it's not analyzed. So remember, I think this was like principle number 3. If you have 2 required entry cases, neither of them are analyzed, then choose the first required entry case. So in this scenario, your LV repair, which occurred first, would be your index procedure. Okay. We have another scenario. Patient had a standalone lead extraction procedure performed by a cardiac surgeon. The following day, the patient had a TV repair. What's the index procedure here? Well, standalone lead extractions performed by cardiothoracic surgeons are required entry, but they're not analyzed. TV repairs require entry, but it's not analyzed. However, there's a risk calculator for the TV repair. So, and remember that little note I talked about. If you have 2 required entry, non-analyzed cases, we had that one little qualifier. If one of them has a risk calculator and the other doesn't, then we're going to enter the case that has the risk calculator. So in this particular situation, we would put the TV repair is the index procedure. Okay, we have another one. Patient has a standalone VAD placement. Later in the same episode of care, the patient has a heart transplant. What's your index procedure? Well, the standalone VAD is optional to enter. You don't have to enter those into our database. Heart transplants, standalone, are optional to enter. But if you work at a site where you generally enter these types of cases and you have a VAD and then you have a heart transplant, we ask that the transplant be the index procedure. Okay. I think we have a couple of more of these. So, TAVR was performed in the cath lab. Subsequently taken to the OR immediately following for an open repair of an LV perforation. What is your index procedure? Okay, so TAVRs are optional to enter. You don't have to enter them in our database. LV repair is required. Always enter required cases over optional cases. So the LV repair is your index procedure. The TAVR is going to be a prior CV intervention. Now I've put a link here because I get a lot of questions about TAVRs gone bad. A lot of times the TAVR is, you're either doing an LV repair or you're doing some sort of aortic repair or you're doing a SAVR when your TAVRs go bad. And this link to this webinar will help you in coding those situations because the basic concepts are the same. And so it's actually a really, I think, useful webinar. It has slides and it's got also the webinar presentation. Okay. Now, before we get into the PROC ID chart, we're going to just talk a few other things about case inclusion, index procedures that I want to bring up because these kinds of questions come up quite frequently too. Transfers to a higher level of care. So I want to start by talking about this because sometimes I'll get questions. Well, the patient came to my hospital and had a CABG, and then he went to another hospital and had an AVR. So it kind of goes along with case inclusion and choosing the index procedure. So I'm going to talk a little bit about this and then some of the principles with these patients that get transferred to a higher level of care that have multiple procedures. So first of all, patients that are transferred to another acute care hospital should be followed until the time of discharge from that facility. Okay, that is the discharge date you enter into the database. So any patient that dies at another acute care hospital after that transfer is going to be a mortality in the database. We ask that you please gather as much of the post-op information as possible from the other hospital, ICU hours, blood use, complications, because, technically that patient is not discharged from acute care, right? They're still in an acute care setting. So we want to continue to follow their care until they are discharged from acute care. So with that concept in mind, let's talk a little bit about what happens if I transfer my patient to a higher level of care and another required entry procedure is performed at the other hospital. Okay, so just think about that for a minute. So you had a patient that had a procedure at your hospital that you entered, and then you transfer them to another acute care hospital. So you're still following that patient, and then they have another required entry procedure done at the other site. So let's talk about what happens in this situation. So we'll look at our example here. The patient had a CABG at my site on 5/15 and then was transferred to another hospital on 5/30. And at that hospital, they performed an AVR. Okay, so if both sites participate in adult cardiac surgery, which most often they do, they both participate in the database. Especially when you're going to higher levels of care, most of them are in the database. So the CABG on 5/15 will be entered as the index procedure for your site. The AVR at the outside hospital will be entered as a re-op valve for your site. The AVR on 5/30 will be entered as the index procedure for the outside hospital for their site. Both sites follow this patient until discharge from acute care. So, because what you've got here is you've got a cabbage procedure at your site, and then this other hospital that you transferred the patient to, who also participates in the database. They have an AVR performed at their site. So you both have index procedures. Okay. So in talking about this scenario, because it does happen sometimes, I get questions. So what happens if this patient dies? Okay. So the cabbage was at your site on the 15th of May, and then you transferred him to another hospital on May the 30th, had an AVR performed at that other site. So, of course, the cabbage is your index procedure. The valve done at the other hospital is a re-op for your site. And then operative mortality is yes for your site because the patient was transferred to another acute care hospital. They never left acute care. You're still following that patient and they expired. That's an operative mortality. Now, let's talk about the other site. So, the hospital that you transferred this patient to. So, the AVR on 5/30 is going to be entered as the index procedure for the outside hospital. And they are also going to code it as operative mortality for their site. And people, like, well, how can that be? A patient can't die twice. Well, one explained that in the database, mortality is counted at the procedure level, not the patient level. So that's really important to understand. So what we have here is we have a cabbage mortality and we have a valve mortality. Okay, so two different procedures, they both get a mortality. It doesn't happen very often, but when it does happen, it really throws people off. Okay, so I wanted to bring that up. Nancy, do you think we should, I don't know how many questions there are, but should we take questions before we move on to the PROC ID or just wait till the end?
We probably should take these few that are here,
Okay.
just because they relate to the case inclusion. So the first question is from Gina. What about a standalone pericardiectomy?
Yeah, so Gina, those are, you can enter those. They're not required, but you can enter those in our database if it's performed from the right phrenic nerve to the left phrenic nerve, meaning it's a total pericardectomy.
All right, and Jennifer's asking if you could please put up the standalone procedures again.
Okay, let me see. Sorry, I think of all those answers.
Pretty far back.
Yeah, my fingers are moving fast. There we go. I think those are the ones Jennifer was asking about. Oh, no, that's the second page. Here's the first page. There's 2 pages, Jennifer.
Oh boy. All right. While we have that up, Janet is asking, are VAD insertions for destination therapy that include an aortic valve repair required for submission?
I think it depends on what they do with that aortic valve, Janet, because sometimes they just do that little part stitch, and that's kind of part of the VAD. I know that's probably not a very good answer, but if they're just doing a little part stitch, then that's generally considered part of the VAD insertion.
All right. The next question, in the anomalous plus cabbage example, and the cabbage was the index procedure, Would the correction of the anomalous be entered under previous CV interventions?
Yes.
That word anomalous is hard to say.
And I got good at it because I had to do it at AQO last year.
Yeah, you had to do that talk. All right, Sean is asking, more anomalous. What if anomalous RCA and cabbage are done at the same time? How do we abstract correction of the anomalous RCA?
Well, Sean, it depends on what they're doing for that anomalous. And, are they unroofing it? Are they translocating it? Or are they just bypassing it? I have a really good slide presentation that I did for the Northwest group, plus I did at AQO, that I'd be happy to send it to you. But basically, if you're doing a translocation and an unroofing, and then you're also doing a cabbage, you're going to code the congenital part, the unroofing, and the cab. But sometimes the only thing they do is just bypass the anomaly. They don't unroof it, they don't translocate it, and then that's just a cabbage.
All right. Beth has a comment. The heart transplant is the index procedure because the LVAD is captured in the mechanical assist device section and previous CV interventions.
I'm trying to find that. So let me find. It's rule number 4 here, Beth. So both of these are optional cases to enter. The standalone bad's optional, the heart transplant's optional. If your site, your surgeon wants those entered and you enter them all the time and you do the VAD and then you do the transplant, we ask that you put the transplant in as the index procedure.
Thanks, Melinda. Can you please list out the analyzed cases and risk calculated cases?
Well, what do we got, Nancy? Isolated cab, isolated AVR, isolated MVR, cab,
MVR
AVR, cab, MVR. We talked about all that last week.
Yeah.
I don't have a slide of that. I guess I should have, but I think that's all of them, right? Multi-valve.
And the multi-valve and
Yeah.
yeah. Oops. All right. Can you please go back to the case of cardiac trauma versus aortic dissection? Is the aortic dissection the index procedure?
Let's see, where were. Oh, here it is. No, the LV repair is because it was the first one. So this is a situation where you have two they're both required entry. The LV's required, the dissection's required, but neither one of them are analyzed. So in that situation, you choose the first one that was done. So that would be your LV repair.
All right. What if both hospitals are within the same hospital system and both participate in STS? This is around transfers, I think.
Well, I'm assuming they don't have the same participation number, Jennifer. So if you don't have the same participation ID, I mean, I don't know, I'm assuming you don't. Then it would be considered a different site because it's not your participant ID. I'm sure they have their own. Does that make sense, Nancy?
Yes, that makes sense to me. Heather, we fully abstract all cases so we have info for internal review. I send all cases to STS. These cases are filtered by STS and only the included ones, or only the analyzed ones, I guess, are included. Yes. So whatever cases you send to us at STS through the IQVIA platform, those cases, all of your cases, only the cases that are analyzed will be included in your risk-adjusted reports.
Yeah, they'll still get some
Yeah.
information on those other
Yeah,
cases.
you will get information on your participant dashboard, but that won't be risk-adjusted data.
Right.
Let's see. Linda, for the cabbage at my hospital, then AVR at the other hospital, the AVR is done by a surgeon that is not in my network. Do I need to abstract it into my data?
No, Linda. So let's get back to that slide. Oops. Okay, so your cabbage at your hospital is your index procedure for your site. The AVR then is at another site, but you transferred that cabbage to that other hospital for more acute care. So you have to follow that patient. You do not put this AVR in as a procedure. It's a complication. It's a re-op valve at your site. Because remember, we only have one index procedure, one data collection form per episode of care. And this is technically one episode of care. This patient had the cabbage, got transferred to another hospital for more acute care time, and had a re-op there. It's one acute care episode. So you have a cabbage, and then your AVR is the re-op valve at your hospital.
All right. Tracy, I had a cabbage patient that went to a higher level of care and got a mitral clip, came back to our hospital, decompensated, got reintubated, and was sent back to the hospital. Do I still use the mitral clip? We don't enter those at our hospital. And how do I do the reintubation prolonged vent information? It's difficult to see the information from other hospitals. I only know about the mitral clip because she came back for 2 weeks.
So the CAB is the index procedure at your hospital. The mitral clip, I'm assuming, is a re-op valve. I don't know the details, but that seems the logical place to put it. And then the patient came back to your hospital. So the patient never left acute care. So what you're going to try to do is get as much information that occurred at that other site, hours, re-intubation hours, ICRs. I know it's hard sometimes to get this information. I suggest you work with your medical records department and let them work with the other hospital's medical record department so that it's done at that level. And it seems to work best if you do it from that approach to get that information that you need. Do the best you can. And in this situation, so this patient had the cab, went to another hospital, came back to your hospital. So I'm assuming the patient was discharged from your hospital the second time around. And so that's the final discharge from acute care. That's your discharge date.
All right. A case with TAVR and PCI was initial procedure, but got complicated with IR angiogram, EGD, then repair of the left ventricular laceration. Is this an eligible case to enter where as all of the procedure was done in a hybrid OR?
Yeah, that LV laceration repair has to go in, Mary, and that's we have to look at your timing and all, but generally when they did that sternotomy to repair that LV, there's some pretty clear instructions in the training manual as to what you put your start time for. And the video link, and I'll be happy to send it to you, will help you with that, or you can send me more questions in the mailbox.
Yeah. Heather has included the case inclusion document link for everyone in the Q&A box. And yes, Sherry, the PowerPoints from each of the training webinars will be on the website for your reference. Just need some clarification. Are analyzed and risk-adjusted procedures the same? During the scenarios, I thought those were referenced separately. Yes, analyzed and risk-adjusted procedures are the same.
Oh, look, I do have a slide.
There you go. All right.
Okay. All
All right.
right. Now we can get going on the PROC ID chart.
Oh boy. More
I'll tell,
fun.
well, I'm going to try to make this easy. I know this is not easy. And it's took me a long time to figure this out. So I think the more you look at it, easier it gets, honestly. So what's the purpose of the PROC ID chart, first of all? Okay. So it's to define the operations that are eligible for analysis with the risk models and associated performance measures. Okay. So each procedure that you add to an analyzed case may or may not affect isolation, depending on this PROC ID chart. Okay. So when these are analyzed cases or risk adjusted cases, and I forgot I had this list in here. I apologize, Amanda. Would have been so much easier than trying to stress my old brain, remember what they all are. Isolated cab, isolated ABR, isolated MVR, ABR cab, MVR cab, ABR MVR, MV repair plus cab, ABR, MV replace or MV repair, cab plus ABR plus MV repair or MV replace. So you can see all the PROC IDs laid out. A few things to know. PROC ID 6 is not risk adjusted and has no composite. So this is number 6 right here. PROC ID 9 and PROC ID 10 is risk adjusted. However, there's no composite score and there's no thresholds. So these are 9 and 10. The multi-procedure composite will include PROC ID 9.
And 10.
Okay. And 10. Sorry about that, Nancy. Remind me to fix that. And 10. Okay. Slide is this? I'm going to make a note real quick. All right. So we're going to talk about how to read the PROC ID chart. I think it's really important that you need to know that when you're trying to read the PROC ID chart, you need to have the data collection form with the sequence numbers on it. That's the annotated data collection form. It makes it so much easier. So where do we find the PROC ID chart? Again, on the database, the For Data Manager section, that's the part you have to sign into. You got to log into that. And then when you get under you hit the training manual, the FAQ summary, you scroll down and you can see that there's the PROC ID chart under additional resources. It was just updated in November 2024. There is a link to the PROC ID chart here. I have taken screenshots. For those of you who've looked at the PROC ID chart, and if we have time, we can look at it, but it's a running document. It's a running document, so the headings don't always carry over throughout the document. So that's why I've done screenshots, just to elaborate on things and make it a little easier to visualize. So this is what it looks like when you first open it up. Now, at the top, you will notice there's 4 PROC IDs here. We've got PROC ID 1, 2, 3, and 4. All the way across, we have columns down. And then the very first column has got the variable short name or the sequence number, okay? So the other thing you'll see is all these little gray lines here that look like it's foreign language. Those are like programming lingo. You just ignore those. I just ignore them. I'm focusing on these white lines. So, for example, isolated cab. This is all down column 1. You can see how these sequence numbers affect it. So, for example, here's a good one, because we were just talking about anomalous coronary arteries. So if you do a cab and you do an anomalous origin of a coronary artery, what this is telling me, so when you first thing you see here is missing. You're like, well, what does that mean? Okay, well, if it's missing, you didn't answer sequence 6515, then it doesn't affect case isolation. If you did a PFO repair in 6515, it doesn't affect case isolation. If you did an anomalous artery, it doesn't affect. Okay, so we'll go through some more scenarios to talk about this. It's basically, whatever's in this column, this sequence number, it's what you code. So if you code missing or you leave it blank, it doesn't affect isolation. If you code PFO or anomalous coronary artery, it doesn't affect isolation. Okay, so going through just the setup of the PROC ID chart a little more, you can see on this screenshot, we have the 4 PROC IDs above, and then we have continuous white lines. Okay, so what it's telling me is these sequence numbers, 3985, 4054, 4131, 2123, 5066, they affect all of these procedures, okay? Because they're going all the way across. So, for example, if you code an aortic procedure 2123, if you say no, doesn't affect isolation. If you say yes, unplanned due to surgical complication, it does not affect isolation. If you leave it missing or blank, it does not affect isolation. The other thing you'll notice on the PROC ID chart is there's some highlighted green. These are just letting you know the changes from the prior version to the current version. Okay, so let's talk a little bit about the PROC ID chart with just some things that I think are important. Again, it's very important when you're reading this to have your annotated data collection form. That's the one that's got the sequence numbers on it, because you can search this document by hitting Control F, and you can put in sequence 4115, and you can see, it'll take you right there to it. You can see if I code sequence 4115 as no or missing, it's not going to affect any of these cases above here, okay? The other important thing I want you to know is not all the sequence numbers for all the procedures are on the PROC ID chart. So if you are doing a procedure like a lead insertion, sequence 4060, can you search it in here and it doesn't exist? Well, if it doesn't exist, it does not affect your isolation at all, okay? So keep that in mind. And you can kind of see they go in order. So 4120, 4125, 4115, you know, 4135, they're kind of sort of in order. So you can kind of get an idea. I mean, 4060, you would think would be somewhere in here, but I don't see it. It's not on this chart. So it doesn't affect isolation if it's not on the chart. So basically, we've got 4 PROC IDs up here. If we say, here's a lead think that that's a lead extraction 4065. If you say yes, unplanned due to surgical complication, it stays isolated. If we say no, it stays isolated. If it is missing or blank, it stays isolated. Okay, so the things in these white rows tell you if you code this way, it's not going to affect your case isolation. And remember it, just ignore these computer null 2, null 2, 1, those are lingo. Just ignore them or they'll confuse you even more. It took me forever to figure out what they were. Okay, so sequence 4191. This is just a tidbit of information because I get lots of questions about this. So this is 4191. This is your AFib lesion location. You will notice that it's used in the isolated cab, the isolated ABR, the ABR cab. Okay, it's used in these three, but it's not used in any of the other calculations. So if it's not used in a calculation, it does not affect case isolation. Okay, they don't use it, doesn't affect. So you'll notice that any procedure that has a mitral valve involved, mitral repair, mitral replacement, any type of mitral procedure, we don't care where you did your AFib lesion location. It does not affect case isolation. It's not used at all. But if you're doing an isolated cab or an ABR or an ABR plus cab, then it does matter where you did your lesion location. If you code epicardial, none, or you leave it blank, it doesn't affect isolation. And that's the same for the isolated ABR and the ABR plus cab. So basically what that's telling you is if you do an isolated cab or an isolated ABR or a combination of ABR and cab, if you do an intracardiac lesion, then the case will be removed from isolation. Okay. Another little tidbit of information, because I get this question a lot, aorta procedures. So when you look for all the PROC IDs, and I've got headings for every one of them, if you code aorta procedure 2123, if you say, yes, I did an aorta procedure, and it was not due to surgical complication, then it's going to remove it from isolation, because the things that don't affect isolation, no aorta, blank or missing aorta, or oops, I made a mistake and now I got to fix it, a surgical complication aorta. I have a little star asterisk here because there is one exception to this rule. Some people are aware of it, they've asked questions about it, but if you have an ABR and you have an aorta complication and you're coding in section M2, your case will be removed from isolation. And it has to do with the PROC ID chart, so which is being worked on. Just wanted to bring that up because some people are aware of that because they brought it up to me. All right. Now, the other thing that's important about the PROC ID chart has to do with mitral cases. Now, we've already identified AFib lesion location. It's not even used in a calculation for mitral cases. So if you're doing any kind of mitral case or anything that involves a mitral case, whether you do an intracardiac lesion or an epicardiac lesion, it doesn't matter. It's not going to affect your case isolation. Another thing that's not going to affect case isolation in mitral cases are tricuspid repairs. So any of the mitral valve procedures, any of them, you can see all the different PROC IDs here that have mitral procedures in them. If you do a tricuspid repair, it does not affect case isolation. Excuse me. So, however, if you do a tricuspid replacement or a valvectomy, it will affect case isolation. I get quite a few questions. I did a mitral valve replacement and a TV repair, but my case is showing up as an isolated mitral valve. Well, it will, because that tricuspid repair does not affect case isolation. You can see it tells you here if you code repair, it's going to stay isolated. Or if you leave it missing, it's going to stay isolated. Sorry, I had to have a little sip of water. So I want to talk about VADs and how they affect the PROC ID chart. So if you code yes, not during this procedure, meaning I didn't do it bad during this procedure, or it's no, or it's missing, or it's pre-op during the same stay, in conjunction with the CV surgery, unplanned, or post-op, the case will stay isolated. So what does that mean? That sounds like a lot. Basically, if you have a planned VAD placement, and I'm talking about the long-term durable device, it will affect case isolation. So this is why it's so important that you know that an Impella of any sort is coded as a temporary assist device. It's not coded as a VAD. And I get lots of questions about that. So remember, Impellas of any sort, I don't care if they're 5.0s or 5.5s or axillaries or whatever, they're coded as temporary assist devices, not VADs. They're not long-term durable devices. The other thing to know about temporary assist devices and ECMO, because tons of questions about this, they do not affect case isolation at all. Temporary assist devices and ECMO timing are in the risk model. We talked about that last week. So they affect the risk model depending on when they're placed. Pre-op placement affects the risk model, meaning they go into the OR for their index procedure with those devices in place. That, of course, adds risk to your procedure. But they do not affect this PROC ID chart at all. But VADs do. So be careful making sure that you're coding your VADs appropriately and that you're not coding Impellas as VADs, because I get enough questions about that it makes me think there's a lot of people out there coding Impellas as VADs, and they're not VADs. Okay. And I'd be remiss to not talk about this when we talk about the PROC ID chart. So the goal is for us to have as many procedures isolated as possible, okay? So that's why we have a significant amount of language in the training manual about, for other cardiac and non-cardiac procedures, we only code the procedures that have a high likelihood of negatively impacting a patient's outcome. We don't want you to be coding minor procedures that do not add risk to the index procedure. Because if you are over coding and you're coding lots of little minor things that may be done in conjunction with a cabbage or a valve, then that's going to remove your case from isolation, because you're probably coding it as other cardiac other or other non-cardiac other or something like that, and it's going to throw the patient out of isolation. So we're going to kind of go through a list. Now, these lists are not all inclusive, and I get questions about this every day. But remember, ask yourself, is this procedure that I want to code, is it going to add risk to the index procedure? So some examples of other cardiac procedures that you should not be coding: removals of ICDs, pacemaker loop recorders, pericardial cyst removal, pericardial drain placement, extensive lysis of adhesions. That's part of the procedure, getting in. ECMO, impella, or balloon insertions. We have a spot for them, in the MAD section. Don't also code them as other cardiac other, okay? Exploration. Oh, let me just open this valve up and look at it. I'm not going to do anything. I'm just checking it out. We don't code that, okay? Wrapping the dilated portion of the aorta to reinforce it, okay? It's just a part of the AVR. Pericardectomies. A lot of times you'll see a partial pericardectomy performed during a cardiac procedure. We don't code those at all. They don't add risk, but they will remove your case from isolation if you code it. MV replacement and left atrium clot evacuation. Well, you're already in the left atrium doing your mitral valve procedure. It's not going to add any risk to just pull that clot out while you're already in there, okay? Because you're already in that space. Some non-cardiac procedures that are minor and do not add risk. And again, these are not all inclusive. Believe me, I get questions every day. The list would be too long. EGDs. They have to dilate the esophagus because they want to pass the TEE probe. That's not adding risk to your index procedure. Open reduction, fixation of the sternal. So putting a sternal plate on, that doesn't add risk to your index procedure. VP shunt that's externalized or simply moved aside. It's part of the procedure. They had to do it to get to the procedure. Plication of redundant hemi diaphragms, either right or left. Repair of pectus. Planned muscle flap. Cystoscopy, so you can put the Foley in. Simple wedge resections, or just doing a little segmentectomy in the lung. We don't code those. Needle biopsies. Reconstruction of flail chest and sternal fractures. You gotta close the sternum anyway. So either you plate it or reconstruct it or whatever. It doesn't add risk to that cabbage or that valve that you've already done. Drainage of pleural effusions and dental extractions, despite the number that you perform. They don't add risk to your index procedure. So think about what you're coding, because remember, the goal is to keep as many isolated procedures as possible. Okay, we're going to go through this. I see I'm running out of time. Okay, talk too much today. Scenario number 1, we're just going to kind of go through these scenarios to see case isolation or not. Patient has a cabbage, AVR, and subaortic stenosis resection, which I have coded in sequence 4051. Is the CAB AVR an isolated CAB AVR, or is an AVR CAB plus other? So you've coded sequence 4051. You can see it right here. Here's your AVR column. You can see that sequence 4051, if you code no, missing, or not documented, the case stays isolated. So you coded yes. So yes will remove the patient from isolation. So this will be a CAB AVR plus other. Scenario number 2, patient has an AVR with a NICS, annular enlargement, which I have coded in sequence 3460. Is the AVR an isolated AVR or is an AVR plus other? I can't find sequence 3460 on the PROC ID chart. So remember, I told you, they're not all there. And if they're not there, they don't affect case isolation. And you can see the number jumps here anyway, 3,400, 3,610. So it's not even there. It's not there. So this is an isolated AVR. So you do an annular enlargement. It does not affect case isolation. Number 3, patient had a cabbage with unroofing of anomalous coronary artery, which I've coded in sequence 6515. Is the CAB an isolated CAB or is it a CAB plus other? Okay, so we're looking at a PROC ID chart, 6515. If I code missing, PFO, or anomalous artery, it does not affect case isolation. Okay, so the answer in this situation is this is an isolated CAB. And I bring this up because you need to think about the isolated CAB measures in these particular patients, and getting documentation as to why this person doesn't go home on certain medications and things. Because we can't make assumptions about that. So, talked a lot about that at AQO this last year when I did that scenario. But scenario number 4. Patient has an MBR with a TV repair and a septal myomectomy. Oh, so we got 2 other procedures. So I've coded sequence 3636 and sequence 4051. Is the MBR an isolated MBR or is it MBR plus other? So we go to our MBR column. We know that the repair does not affect isolation. But what about this septal myomectomy, which is a subaortic stenosis resection? That's in sequence 4051. So we go to 4051. We come across and it says if I code no, missing, or not documented, then my case stays isolated. Well, you coded yes. So what does that mean? That means that this is an MBR plus other. So again, the TV repair doesn't affect case isolation in any kind of mitral procedure. However, you also coded the subaortic stenosis resection as yes, which will remove the case from isolation. Scenario number 5. Patient has a cabbage with a permanent pacemaker with an LV lead placed in a planned extraction of a capped RA lead, which I've coded in sequence 4055, sequence 4060, and sequence 4065. Is the CAB an isolated CAB or is a CAB plus other procedure? Okay, so sequence 4055, isolated CAB, not used in this calculation. Okay, that means it doesn't affect case isolation. Sequence 4060, well, it's not even on here. And we go from 4055, 4060. If it's not on it, it doesn't affect it. Sequence 4065, come over here. Yes, unplanned surgical complication, no, or missing. Well, this was a planned extraction. So what you have here is you have a CAB plus other. So again, 4055 is not used, doesn't count. 4060 is not even on the PROC ID chart, so of course it doesn't affect isolation. However, you coded sequence 4065 as yes planned. This is going to remove it from isolation. So that will remove your cab from isolation. Scenario number 6. Patient has a cab MVR with an intracardiac maze, which I have coded in sequence 4191. Is the cab MVR an isolated cab MVR, or is it a cab MVR plus other? Okay, so remember what I told you. Sequence 4191, it's not used in any of the mitral calculations. Okay, we don't care. It's not going to affect we care where it was, but it's not going to affect your case isolation at all because you're already in there. You're already inside there. So it's not like you're opening the left atrium and doing something special. You're already in there fixing that mitral valve, okay? So the answer is an isolated cab and MVR because 4191 is not used in the calculation. So if it's not used, it doesn't affect case isolation. Sorry, I'm running over. I'll just have a little bit more here. Scenario number 7. And I'm bringing this up for an important reason. Patient has a cabbage. During the procedure, the RV is inadvertently lacerated, and the surgeon performs an RV repair. I coded sequence 2140 as other cardiac other as unplanned due to surgical complication, and then I coded sequence 4135, which is other cardiac other. Why is my cabbage showing up as a cab plus other since the RV repair was due to surgical complication? I thought if the other procedure was due to surgical complication, the cab would stay isolated. It's a very logical question. Very good question. So the answer to this is there's a little bit of a flaw in the PROC ID chart. If you look at sequence 4135, if you code no or missing, the case stays isolated. It doesn't say anything about unplanned due to surgical complication. So we discovered this pretty close to after the inception of the new version, and we do have we have a workaround in the training manual. So and I'm going to go over that with you, but for sequence 4135, it does not matter if the procedure was performed for surgical complication or not. If you code 4135 as yes, the procedure will fall out of the isolated category, and we don't want it to fall out because it was due to a surgical complication. Okay. So what we've instructed you to do is you can answer yes to 2140, and you could say it was unplanned due to surgical complication. But when you get over to this other cardiac other procedures, just answer them all no. Just answer them all no. This is our workaround until we get to the upgrade and update the PROC ID chart. And I can't tell you the number of questions I get about this every week. So I wanted to present this on this call so that you're aware of this, because with the number of questions I get, it makes me wonder, it makes me think, oh, I need to make more people aware of this. So it is in the training manual. It's been there for a very long time, and I did want to point that out. That's the end of this presentation. Next week, we're on Thursday, and we're going to be talking about harvesting the data and the DQR report. We're going to go through, and that will be Thursday, March the 20th at 12 p.m. Central Standard Time. It's the only deviation from Tuesday that we've had. So anyway, thank you very much for your time and attention, and we'll entertain questions. I apologize I ran over a bit.
That was fabulous information, Melinda.
Thank you. Thank you.
Thank you so much. We do have some questions. Lindsay and Christine have questions about risk-adjusted and composite scores. What are the differences between those?
Well,
Oops. So your
what do you?
composite score is your star rating. So all of that data, avoidance of mortality, avoidance of morbidity, and for CABG, your process measures, your medications, and use of IMA. Those are your composite scores. They are risk adjusted. And then risk adjusted scores or data, you can have risk adjusted data, but it doesn't necessarily go into your composite score, if that makes sense. So you get risk adjusted data for multi-valve, but multi-valve by itself is not included in your composite scores. That's just an example.
Yeah, and we're going to talk about that more on session 5 when we talk
Right.
about the national report overview, and we'll be talking about the star ratings and composite scores. And last week we talked about risk risk modeling and the risk variable chart.
Right. Right. And so your risk adjusted data would follow, I mean, all of those risk follow the risk model. The data follows the risk model, and you'll get an observed over expected, and then a risk adjusted rate. But we'll talk about that in an upcoming webinar. Judy and Deborah had similar comments about the PROC ID chart. So in other registries, ACC and NISQIP, the PROC ID chart is called an interactive decision tree, and it is interactive. So
Yeah, I know.
Judy is
Carol,
asking about that.
yeah, Carol's not on anymore.
Yeah, Carol's not on anymore.
We've talked about that, Judy, as a possibility. We just haven't gotten to that yet. I mean, there's some consideration for that, but I think there's been a few obstacles. So I think there's some things we're working on. I wish, and Carol's not here to elaborate.
So Kim is asking, how does PROC ID 6 and PROC ID 9 differ? Does an AVR plus MVR fall into both PROC IDs? So AVR plus MVR, that's your aortic valve replacement plus a mitral valve replacement, is part of, or is a subset of PROC ID 9, which is AVR plus MV replacement or MV repair. So PROC ID 6 is a subset of PROC ID 9.
Yeah, and I had Hannah explain. I think it was Hannah explained that to me a little bit. It made me understand it because sometimes I have difficulty understanding things. But the subset for PROC ID 6 was pretty small, and so PROC ID 9 expands on it because it also adds the repair part of the mitral valve in addition to the AVR and the MVR. So it's a bigger population of people.
Right. That's a good point. Kelly, sorry, but what do you mean no composite score? Isn't there the new composite star rating? Thank you. Just confused. I thought the AVR plus MVR is risk adjusted because it has a risk score. So AVR plus MVR, PROC ID 6, is risk adjusted, but it has no star rating.
Maybe I'll add that to the slide.
Yeah.
No star ratings. That'll be probably a better terminology, make it easier to understand.
Yeah.
Thanks, Kelly.
Yeah.
And Nancy.
Christine, please repeat the AVR aorta statement you made that affect isolation.
Okay, so All right. So when you look at the PROC ID chart, you'll see aorta procedure 2123. If you code no, yes, unplanned due to surgical complication or missing, it does not affect case isolation. However, when you are doing an ABR and a combine, and you have an oopsie, I made a mistake, I got to fix my aorta now because I dissected my aneurysm, ascending aorta, and you have to do an unplanned aorta procedure. You are not coding your aorta. I mean, you're coding in the section M2 section. Let's see if I have a slide that actually shows that what I'm talking about. Don't know if I do. Yeah, here it is. Okay, so it has to do with what you cut, where you're coding the ABR. So in here you can see that sequence 3395 is used, but when you're in the M2 section, it's not sequence 3395. It's a different sequence number for aortic valve replacement. And so that sequence number is not on the PROC ID chart. So if you are doing an ABR, you accidentally mess something up and you have to do an ascending or some other type of aortic procedure, you're coding your ABR, and I can't remember the sequence number. I think it's 4049 something. Anyway, you're coding it in the M2 section. Where you're coding that ABR replacement is not on the PROC ID chart. So you're going to get a freebie. You're getting a freebie. That ABR is going to be removed from isolation because of that. Surgeon leadership, Carol, everybody's aware of that needs to be updated, and we are working on that. That's probably not going to be until the upgrade. I think that's what Nancy said. But we are aware of the situation, and I wanted to point that out because I get questions about it quite often. And that's the reason.
Right. Abdul, how can I code post-procedure event for ECMO procedure performed outside of the operating room?
Well, I don't have my data collection form pulled up, but I'm assuming this is a post-op, like they're just putting the ECMO in after the index procedure, Abdul. So you would code this as a go into the MAD section and code it was performed post-op, and then ECMO post-op after the index procedure is also coded as a re-op other cardiac. And if you have further questions or that's not the exact scenario you're talking about, please send me that information in the FAQ mailbox and we can work through that together.
And Judy is asking if a CABG plus tricuspid valve repair is an other. Would be a CABG other.
It is. Yeah, because the tricuspid language, Judy, is only for in conjunction with mitral valve procedures, okay? So any of the procedures that have mitral valves done, then the tricuspid valvectomy does not, the tricuspid repair does not affect case isolation.
Thanks, Melinda. And then Glass remembers the interactive PROC ID being available many years ago, and it was user-friendly.
Actually, I can add a little 2 cents to that. You're talking about we set up a website, and this is going way back.
Way back.
Yeah, way back to 5, I think. And the whole reason that we came up with that is because there was a change to the way PROC ID was calculated. that couldn't be handled directly in the way the variables were defined in the specs. And so we needed to do something that made it where it could not be displayed in a chart. There was like too many conditions. Like once you got down to a certain point, then there was a flip to it that you had to do programmatically. It couldn't be displayed directly in a chart like that. And that was the reason why we came out with that at that time. And that's why that's been the only one that we've come up with an interactive way of figuring out what the PROC ID was. And I appreciate you saying that it was user friendly because I programmed it.
Way to go, Paul.
Yeah.
Okay, Paul, now you know what your new assignment is.
Yeah, you just opened yourself up for more work.
You walked right into that one, Paul.
All right. Lots of kudos for Melinda. Beth says all your work is so much appreciated. Lori says, great presentation. She needs to start drinking to absorb all this. I would agree. Michelle says, thank you. Mary says, thank you. The PROC ID chart is a monster. I would agree. It can be kind of difficult, challenging. And then we have another question from Lynette. What is the difference in a VAD placed and removed pre-cabbage versus one removed during cabbage?
Well, if it's removed pre-cabbage, like not during the same procedure, like the standalone procedure, it won't affect the cabbage isolation at all because it's not in, right? And it wasn't done during the procedure. However, if you remove it during the procedure, you actually did the cabbage and you're going to take your VAD out or vice versa, they're done at the same time, then it does add some risk. So it will remove it. And if it's a planned removal. Yeah. So.
All right. Thanks, Melinda. Jackie has a suggestion. She agrees with all the kudos above, but maybe suggesting a short tutorial on how to get into the training manual and easily search would be good for new users. A lot of us had no preceptors and had to figure it out all on our own. These webinars are amazing. Been abstracting for 2 years and just what she needed.
Yeah,
Oh,
Jackie, we talked about that on session 1. If you weren't able to catch that one, I think it's already on the YouTube channel.
yeah. And these webinars will be on the YouTube channel along with the slides. You can go back and reference. Heather says, thank you for the PROC ID information. Fantastic presentation, much appreciated. Carol says, thank you, Melinda. PROC ID is tricky. Appreciate you spending time on it. And then Joy is asking about any plans for the new version to have any pullover from Epic. We talked about that a little bit in the software specs training webinar. At this point, only demographics are pulled over.
Yeah, the obstacle with that is getting it certified, since every single
Right.
site has something different. It's making it very difficult to come up with a good way to certify that it's being done correctly, and we're keeping up the integrity of the data. So we are working on it, trying to figure out a solution, but we don't have one right now.
Thanks, Paul.
Mm-hmm.
Kelly says she thought the AVR and MVR is part of the new star rating. So AVR and MVR is part of multi-valve, and multi-valve will be a part of multi-procedural. So all of those cases that are included in PROC ID 6 are a part of PROC ID 9, and PROC ID 9 and PROC ID 10, along with PROC IDs 1 through 5, which are your isolated cabbages, isolated AVR, MVR, and then your AVR cab and MVR cab. All of those will roll up into multi-procedural. And you will get a star rating for those cases. Can we get a tutorial on the PROC ID chart for those that are new to the registry?
Well, that's what I was hoping to accomplish on this call. It takes time. I've given you the principles, the general principles, but if you have any questions, you're having trouble with it, please send me a question in the mailbox. It just takes a little time to get used to reading it and figure it out. If you have a suggestion of how I can improve the presentation, please provide that too. That would be helpful.
Let's see. We only have time for a few more questions. I've got to log off to another meeting. So just quickly, around risk variables, Mary's asking if a patient was a hard stick and blood is taken prior to induction, but in the OR, can this result count for some of the labs that are included in the risk models?
No, has to be prior to OR entry. Yeah.
Yep. If ECMO is placed after the index procedure and needs to be coded as mechanical assist device and re-op cardiac, what about Impella?
Same principles. Yep.
Yep.
That's in the training manual under re-op cardiac.
All right. Thanks everyone for joining. Jennifer says, thanks to everyone at STS. You're amazing. Thanks from Denise, and Jackie says she'll be going back to watch the videos. And then Michelle made a comment about not everyone has the Epic in regard to the AI question, I think. All right, so thanks everyone for joining. We appreciate you. Our next training webinar is Thursday the 20th. We will have a quality webinar on March the 19th, and we have a speaker for that one. So please be sure you tune in for that.
Bye, everybody. Thank you so much.
Thanks so much.
Thank you all.